Hello and welcome to our latest Defeat Diabetes webinar. And we're very privileged today that we have the great Dr. Ken Berry live from Tennessee, I believe. But
That's correct.
I'm not going to introduce Ken. I'm going to let him tell you his story. So firstly, welcome, Ken, and welcome to Defeat Diabetes webinar. And tell us a little bit about your story, about, where you, how you finish up where you are now.
Well, thank you, Peter. Thank you for having me. So I was classically trained as an allopathic physician at a state university. And in the first few years of my medical practice, the totality of my nutrition advice for people who were overweight or obese was to join Weight Watchers and join the gym. Eat less and move more. That was your problem. Get off the couch, eat some rice cakes, and go for a walk. And that seemed to work well. No one was offended by that. But a few years later, I started to gain weight. And I lived in scrubs. And so, as you know, they have a drawstring at the waist. And since I'm 6'3", I had to wear the extra large or they would be too short. And so there was lots of drawstring. And I noticed that I had left less and less string dangling as the years went by. But one day I thought, I'm just going to jump on the scale, and I weighed 297 pounds. And I thought, that's bad. That's a lot. I mean, I'm 6'3". I thought I carried it well, but still, that's too much. And so I thought I better get some lab work. And turns out I was pre-diabetic and my inflammatory markers were high. And I almost certainly had a touch of fatty liver, the AST, ALT starting to creep up. So I thought, okay, I can't, being a Southern boy, I'm ruled by the precept of common sense. And it just doesn't make good common sense to go into a patient's exam room and tell them they need to lose some weight when this button on my shirt right over my belly button is in danger of popping at any moment. Right? And so I had to fix me. And so the American Diabetes Association handout that I'd given to thousands of patients, I thought, well, I'll take that home and I'll start following that because I was eating a lot of junk. There's no doubt. And I'll start jogging because I hated jogging. And I felt like I was a sinner because I was severely obese and pre-diabetic. So I needed to atone for my sin. So my sacrifice was jogging 3 days a week. So I did that for the next 90 days. I followed the ADA. I got rid of all the bacon and animal saturated fat. Ate only whole grain bread, lots of fruits and vegetables, lots of fruit smoothies. And 90 days later, I had gained 3 pounds and my A1C was worse. And it was at that moment that I decided that I didn't know a damn thing about human nutrition because that should have worked. And so also, Peter, you can imagine being a country boy, I thought, I wonder, because I suspected my patients were just laying on the couch eating donuts, right? They weren't following my advice. Now I was faced with the very likely possibility that they were following my advice, but my advice was just idiotic. And so at that point, I thought, well, I've got to figure this out. And so I started reading books. I looked at all the nutrition literature, and I found it to be wholly unhelpful. And so I started reading books. I read Dr. Atkins, Dr. Lauren Cordain, Mark Sisson. Those are my first 3 books. And I thought, well, that's exactly backwards to everything that, I've been taught and thought that I knew in my arrogant ignorance. But I'm going to give it a try. So I tried that for 90 days. Lo and behold, I'd lost, 20, 25 pounds. And A1C was already coming down. Just making those few changes, basically low carb is what it was, with more meat and more saturated fat. And I added bacon back in. So my life was once again complete. So then I kept reading about keto in my nutrition studies. And it was just becoming a little bit popular. And I thought, well, low carb, what I've effectively done is I'm eating fewer carbs. Maybe I should just eat even fewer carbs. But I still didn't portion control. I didn't calorie count. I just cut the carbs even more. And so now I'm eating a ketogenic diet. And man, the weight started coming off like crazy. My A1C went back to normal. My inflammatory markers back to normal. My liver markers back to normal. Heartburn that I'd had, severe heartburn my entire adult life, was 80% gone. I went from taking 2 proton pump inhibitors a day to Nexium. I got all the Nexium samples. None of my patients got those. I went down. Now I took an occasional Tums or a swig of apple cider vinegar, and that controlled my heartburn. And so I kept seeing this Sean Baker guy on the internet, and I had a Facebook page, and I said, hey guys, let's do a carnivore month. Because if you think about this from a carbohydrate standpoint, carnivore is the lowest carbohydrate option out there, right? Carnivore is keto. You're eating 0 carb effectively. So after that month of the carnivore challenge with my Facebook group, it occurred to me that I hadn't touched the apple cider vinegar all month, and I had lost my roll of Tums, and I didn't know where they were, but also I didn't care. I had 0 heartburn that month, and then also had lost even more weight, felt better, just, you know the stuff you hear from people all the time. And it was that was the moment that I just said, okay, so we've got nutrition completely wrong. And that's when I really went to work with the YouTube channel and just really reaching out to people, because I had been giving my patients not only bad nutrition advice, but looking back now, I consider that advice harmful. I was doing harm my first few years of medical practice by giving that idiotic advice. And so I thought, well, the only way I can atone for that is to teach as many people as I can the right nutrition advice. And so from that day to this day, and many days into the future, I hope, that's what I'll be doing.
Yeah. And how have your patients reacted to that?
Well, initially, I considered a ketogenic diet just a temporary weight loss hack because I was just learning about it. I was not in any way confident that it was safe long term. It sort of rhymes with ketoacidosis, right? Ketosis. So I was like, I don't know, maybe. But for my most severely obese patients, this is going to be fine to do this for 3 or 6 months, right? For my diabetic patients with the highest A1C, this is surely going to be safer than running around with an A1C of 14. If they could do this diet and lower it down to 7 or 8, that's got to be worth the risk of a ketogenic diet, right? But now, looking back now, I realize that actually was the ethical thing for me to do at that time, because I had not read all the literature. I did not know that the ketogenic diet has kind of come, it bubbles up about every 2 decades, and it has since the early 1800s. Some doctor will rediscover that, and he'll promote it, and he'll get famous, and then it just kind of dies out. But the more I read about keto and carnivore, the more I realized not only is it safe for literally everyone, it's probably, being in ketosis is probably our default state as a species. And so then I took this little segue and started looking, because I thought, it's probably important what human beings used to eat a long time ago. Seems like that should be relevant, right? Because if your uncle died and you inherited a cow and you didn't know anything about cows, you would say, what do I feed my cow? Well, I would do an internet search and say, what have cows always eaten? And Google would say, grass. And I would say, oh, okay, well, I'll feed my cow grass. And my cow would be very happy with that, and so would I. Well, it occurred to me, maybe I should look at what we ate 1,000 years ago. Is that known? I don't know. I'm not an anthropologist. What about 5,000, 10,000, 20,000, 100,000 years ago? Do we know what we ate back then? Because I feel like that would be very important. Turns out we do know. Through this nifty scientific process called stable isotope analysis, we can tell what our ancestors ate from a bit of tooth or a bit of bone or cartilage and connective tissue if we have it. We can tell exactly which kind of plants they ate, whether they were C3 or C4. We can tell if they ate predominantly seafood or predominantly land mammals. We can even tell if they were eating other carnivores. So, man, I was like, whoa, look at this trove of literature. This is going to tell me what our ancestors have eaten as far back in time as we can go. And to my surprise, and also my pleasure, I found that they ate as much fatty meat as they could get their hands on. They ate it as often as they could. If they could get enough fatty meat, they wouldn't eat anything else. And it was at that point that I stopped just recommending keto and carnivore to my most obese patients and my most uncontrolled diabetic patients. I started recommending it to anybody who had any of the markers of metabolic syndrome. So if you're a little overweight, if your triglycerides are high, if your blood pressure was high, if your blood sugar, your insulin, and I also learned about insulin, one of the most powerful tests that a doctor can order. And then I learned next that 99% of doctors never order a fasting insulin. And I was like, man, I've got so much work to do. I've got so much education to spread. And now I recommend a ketogenic diet to virtually, or a carnivore diet to virtually everyone. I've become so enamored with both of them that I now refer to them as the proper human diet spectrum. I believe the degree to which you're not eating keto or carnivore is the degree to which you're going to suffer from some degree of metabolic disease.
Yeah, very similar journey to my own, and it's amazing how many people who are sort of prominent, I guess, in the sort of the low carb keto sort of world have come via their own health journey, I guess, and like you, I mean, I was preaching the low fat diet for God knows how many years. I hate to think, and I was talking to someone the other day about packing my children's school lunches. I mean, it's amazing any of them who even survived into adulthood. The crap that I used to put in their lunches, and I thought I was doing the right thing at the time, and so on. But yeah, I guess we all want to make up for lost time. So Ken, let's take the case of let's say a middle-aged patient comes into your office. They might be pre-diabetic or type 2 diabetic. They're on a pretty traditional American diet, if you like, a lot of fast food and high carbohydrate. I mean, what's your approach to sort of, I guess, convincing them or educating them that low carb keto is the way to go? They're obese, they're pre-diabetic or diabetic, and so on. How would you approach that sort of patient?
Yeah, so the first thing I would do these days is I would order a continuous glucose monitor and teach them how to wear that. I would check a full panel of lab work, much more than the average doctor checks as a baseline. I would show them their lab results, and then I would instruct them on using the CGM that this is going to teach you what to eat and what not to eat. In Western society, most people think if they have a problem, they must buy a product to fix that problem. They need either a pharmaceutical or a nutraceutical. You have to add something. And so I would instruct this patient, the thing that you're going to learn from your CGM is what to subtract. Anything that makes your blood sugar spike, you're not going to eat that again. Because, and then I'm a very plain spoken person. You may not know that about me, but I tend to just say it like it is. And I would show them some pictures of a gangrenous foot, and somebody on dialysis, and somebody in the nursing home because they had had a crippling heart attack. And I would say, this is the future for you. One of these, I don't know which one, or some combination, but that is guaranteed to happen to you if we don't reverse your type 2 diabetes. Wait, what's that you say? Reverse? Yes, you can reverse it. It's not chronic and progressive. You can reverse this completely back to normal. Now, I would also offer this patient the pharmaceuticals, the standard pharmaceuticals. But I would caution this patient that when you read the literature carefully, even though we use 2 or 3 or 4 prescription medications to get your A1C down and your blood sugar down, it doesn't seem like that really lowers your risk of blindness, kidney failure, heart attack, stroke, amputation as much as it should. And what I would like to do for you is lower your risk back to baseline. I want you to have no increased risk of those terrible things happening to you. And this is how we're going to do it. You became a obese type 2 diabetic because of the food you ate. And so what we're going to do is change the food you eat so that you go right back to that normal, healthy individual you used to be. I would start something like that.
Okay, and I'm your patient. I'd say, oh, but I couldn't possibly do that, doctor. I couldn't give up bread and fries and so on. No, I couldn't do that.
Yeah. So we would continue this discussion, and I would say, now, do you believe that eating bread is healthy, or do you just like the taste? Do you believe that eating that baked potato is that a health food? Is it full of nutrition? Or do you just like the taste? And we would have that discussion and tease out, because many people have bought into what I call the false choice, where back when they were eating donuts and Doritos and drinking Pepsi, they knew that was shit. They knew that. They just didn't care. But then they're diagnosed with diabetes, or they get overweight or whatever, and they're like, I've got to do better. And they go see the average doctor, and they're given the American Diabetes Association handout, or they're told to eat a plant-based diet. And so they replace the Lucky Charms with just cornflakes. And they think they're doing better. And they replace the white bread with whole wheat bread with seeds on top, and they think they're doing better. And they replace the Pepsi with fruit juices, fresh squeeze. They squeeze them themselves, and they think they're doing better. You see how that's a false choice? And then when they come back in 3 months and they get their labs rechecked, it's no better, or it's worse, right? And then they get frustrated and they quit. So I would want to know, do you really believe these things are healthy and nutritious? Are these health foods, or do you just like them? And is it possible that you're addicted to sugar? Because sugar addiction is a very real thing. And then we would continue that conversation.
Okay, I find that there's two issues that patients always bring up. The first one is, oh, what about all that saturated fat? You're telling me to eat meat and various. We've been told for years that saturated fat is cholesterol is evil. So
yeah.
How do you respond when patients say that?
I would tell that patient that my number one priority for you is to keep you alive and to keep you disease-free. That's my goal as your doctor. And I would explain to them the research that I used to make my YouTube video called How Not to Die of a Heart Attack. Because a heart attack, that scares everybody. Everybody's afraid of that, right? And I would say, do you know what, because you're worried about the saturated fat. So I assume you're worried about your cholesterol, your LDL cholesterol. Is that right? And they would say, yeah, that's right. I heard that's really bad if your cholesterol goes up and you're eating animal fat. I mean, my God, how can that be good? And I would say, well, what do you think is the number one cause of heart attack? What's the most dangerous thing you can have? Do you think it's high LDL cholesterol, or do you think it's type 2 diabetes? And then I would show them the research if they answered incorrectly. And I would say it's type 2 diabetes. It's 10 times, 15 times more dangerous than high LDL. Well, what about obesity? Do you think that's more dangerous, or high LDL? And we would just keep going down the list: metabolic syndrome, smoking, because I assume you're a smoker too. If you're eating all the jelly donuts, you probably smoke. And hypertension. We would talk about all the leading causes. And I would say, now, do you notice I haven't mentioned LDL cholesterol? And that's because it's number 14 on the list of things. And so what I want you to do, dear patient, is to focus on the top 10 most dangerous things. I want you to spend the most of your effort and your stamina and your willpower reversing type 2 diabetes, because that's the most dangerous. That's the bazooka aimed right at your head, right? And then the next thing is metabolic syndrome and obesity. And you got to quit smoking. Come on, don't be an idiot. Quit smoking. Right? Those are the shotguns aimed at your head. So at number 14 on the list is elevated LDL cholesterol. That might be a pellet gun aimed at your shoulder. Yeah, that's going to hurt a little bit maybe, but it's not going to kill you dead like type 2 diabetes and all the other leading risk factors. And what about total cholesterol? Well, my God, it's so far down on the list, it's not even listed in the study. Nobody cares about what your total cholesterol is. Nobody cares much what your LDL cholesterol is, but you, my dear patient, should care very, very much what your A1C is, and what your fasting insulin is, and what your triglycerides are, and what your waist to height ratio is. And we would learn how to measure that at home for free. And then we would continue this discussion.
Right. Okay, you've convinced me. So the next thing that people always complain about is that, and especially doctors always say this, if you talk to doctors, fellow doctors, skeptics, who say, what about, keto? They say, oh, but it's not sustainable. People can't sustain a ketogenic diet. What's your experience with that?
Well, my experience is that when somebody is just trying keto or a carnivore because it's popular, they might not stick to it. But every single patient that I've ever counseled who's had a health scare, chest pain, went to the A&E, or a mini stroke and then the symptoms resolved, or a hypertensive emergency and had to go to the emergency department, those people who are ready, or their wife's about to leave them because they're too damn fat, right? If they've had enough of a pain point, then they're motivated. That's all I need. I just need you to be somewhat motivated. And then I'm going to tell you, you get to eat all the bacon you want. You get to eat all the steak you want. You can have, if you like veg, you can have some veg. If you like low carb nuts, you can have nuts. You can have berries. You can have thousands of different things on a ketogenic diet and hundreds of different things on a carnivore diet. And the beauty of these things are they're so full of healthy animal fat and healthy animal protein. And I'd always would phrase it that way, because I think that people are so used to thinking that animal fat and animal protein are somehow magically unhealthy. I would repeat that message very often, because that's the truth. Remember the cow eating grass, right, Peter? Well, humans have been eating animal fat and animal protein for just as long as we've been drinking water and breathing air. It is our ancestral food. There is no food that we've been eating longer. If you think we've been eating wheat, whole wheat, right? Not even GMO wheat, but ancient einkorn or emmer wheat. We've been eating that for about 9,000 or 10,000 years. We've been eating meat for millions of years. It is our ancestral food, okay? This is very clear. This is not debatable. So you're eating the food you're supposed to eat as a human being, a Homo sapiens sapien. It's going to improve your health. It's going to be delicious, and you get to eat until you're comfortably stuffed. You no longer have to portion control. You no longer have to drink that tiny can of Coke, okay? You can have as much sparkling water as you want. You no longer have to eat that palm-sized portion of this, that, or the other. You can eat ground beef or steak or salmon or whatever until you're stuffed and couldn't possibly eat another bite. Then you're going to be full for a long time. You're not going to feel like snacking in an hour or two or three. And that's going to make this much less difficult for you. I didn't say easy. I said less difficult. But the long-term goal of this, my dear patient, is to keep you healthy, happy, and alive for a long damn time. And if we work together on this, that's exactly what will happen, unless you get hit by a bus.
Okay. So Ken, I want to take you back to something you mentioned earlier, and that's measuring serum insulin. Because it's something that, as you very correctly said, same in this country, that most doctors look at you strangely when you ask for can you do, when you're doing my blood, my labs, can you do a serum insulin? They look at, well, why would you want that?
Yep.
Yet it's arguably the most valuable test you could do.
Absolutely, and it flabbergasts me, because checking serum insulin gives you superpowers as a healthcare provider. You can literally predict type 2 diabetes 10 years before it starts if you'll check a serum insulin. You can say, hey, you're pre-diabetic even before the A1C goes up above 5.6. Or I don't know if you guys use that scale there. Maybe a different scale.
Yeah.
Same? Okay.
Scale.
Yeah. So
that's about the only thing we do the same. But the HbA1c is the same.
If you explained it to a doctor that way, you would expect every doctor to adopt that test immediately, because the truth of the matter is somebody can have a normal A1C, and if they fasted overnight, they can have a normal serum glucose, but be severely hyperinsulinemic. But if you don't check the insulin, you have no idea that this person is already pre-diabetic, already effectively has metabolic syndrome, in my opinion. I think elevated insulin should be added to the criteria, and I think it will be within the next 3 to 5 years if you and I have our way. But you literally, it's like you're a fortune teller, a soothsayer. You've looked into the future and said, you're going to develop type 2 diabetes. You have to stop right now. What doctor wouldn't want that superpower? It's like you're a medical avenger.
It's remarkable, isn't it? And this is reluctance to. Do you think it's just the lack of understanding of the role of insulin in prediabetes
Yes.
and so on?
Yeah, I think that's the large majority of it. The tiny percentage of me that's conspiratorial in nature thinks that no doctor wants to check a fasting insulin because it would immediately reveal the fallacy of their plant-based diet recommendation, because you would immediately see what the plant-based diet is doing. But 95% of me believes that the average doctor has forgotten their basic physiology and their basic biochemistry and pathophysiology. They've just forgotten all that. They've gotten so used to whipping out the prescription pad and writing the prescriptions, now it's electronic, that they just have forgotten the basics of physiology, and they've forgotten what insulin does, what elevates it, what lowers it. They just forgot all that. Or maybe they never learned it to begin with, but that would be worrisome, wouldn't it?
Absolutely. Yeah. Now, as far you mentioned medications earlier, and there are very obviously lots of different diabetic medications, but obviously they're the two most, I guess, controversial medications in the nutrition world are statins and the GLP. What statins? I mean, a patient comes into you and then they've been to see their cardiologist, and the cardiologist said, you've got to go on. Your cholesterol is a little bit high. You've got to go on statins. How do you respond to that?
Yeah, I don't recommend statins for any patient for primary prevention of cardiovascular disease.
Now, explain what you mean between the difference of primary prevention and secondary and so on.
So if the patient has a high LDL cholesterol, but they've never had a heart attack, they've never had bypass surgery, they've never had a stent placed, then I'm going to say you do not need this. There's no research that shows that this is going to do anything other than maybe add 2 weeks to your life if you take it daily for the next 20 years. Maybe. And so I would counsel that it's a waste of time, a waste of money in the United States, wasted copay. I don't think you guys have copays there, do you? But yeah. And so, but now if they had 2 vessel bypass, we might talk about a low dose of a statin along with some coenzyme Q10, right? And I would never put any patient on high dose statins. I just would never do that. But I might start a low dose. If they've had a heart attack that's documented, we might talk about a low dose of Crestor, rosuvastatin, but always with coenzyme Q10 because the statins deplete it so severely. But for primary prevention, so if you've had a heart attack or a bypass, then you're taking the statin for secondary prevention. You've already had a heart event, right? But if you've never had any of those things, you're taking this for primary prevention. And the research supporting that, in my opinion, is atrocious. And keep in mind, all the research was paid for, designed by, and conducted by the company that's going to profit from the statin medication once it's FDA approved or whatever the similar association is in down under.
Yep. Yeah.
Now, let me also add this, because some doctors are like, oh, you don't want to take a statin A. Okay, well, we're just going to start you on this little injection called Repatha or Praluent. And in my opinion, those are probably worse than statins because they're going to lower your LDL cholesterol to sub-physiological levels that even no normal human would ever have an LDL that low. And once a doctor goes back and refreshes themselves on their physiology and their biochemistry, and they remember all of the incredibly important things that LDL cholesterol actually does, that's good for you, they will probably hesitate before prescribing something that's going to just nosedive your LDL cholesterol like the PCSK9 inhibitors.
And obviously, the elephant in the room at the moment is the Ozempics of this world. And I'm sure every day you have a patient come in and say, "Doc, I want to go on Ozempic." They might be overweight or particularly for weight loss. I guess
Sure.
it's most controversial. I mean, um, what's your approach to that patient?
Well, I'm very concerned about the GLP-1 at the new higher doses that they're now being prescribed at, because there's no long-term safety data that shows that those higher doses are safe. Now, we've been using a GLP-1 in one form or another for about 15 years now, but it was at much lower doses, right? And it was only for type 2 diabetes. It was some doctors would use it off-label if you had severe obesity, but not many. But now this new higher dose, and so I actually have kind of a mixed opinion on this, and it gets me in trouble with my low-carb, keto, carnivore fellow physicians sometimes. If someone comes to me and their BMI is 45, they're just severely, like life-threateningly obese. They barely got to the doctor's office, right? They had to call the ambulance to come and take them from their apartment to the doctor because they can't drive anymore. They're too big. Or if somebody's A1C is 14 or 15, I'm not opposed to using the lower doses of the GLP-1s for 3 to 6 months to help them with the weight loss, to help them with getting the blood sugars down and the A1C down, and this is contingent on this, as we learn about and start to implement a proper human diet in that 3 to 6 month window. And so, yeah, we'll do that as kind of a get out of jail free card to keep you out of the nursing home after that catastrophic heart attack or stroke. But we're not going to do it long term. We're not going to do it at the higher doses. It's going to be a short term thing, but we're still going to be talking about a proper human diet each and every visit. I'm going to be sending you emails. Hey, what was your diet today? Depending on what level of care you've gotten from me, you may be sending me pictures of your food before you eat it. But that's the way it has to be. I feel like that the high dose GLP-1s is a very large, uncontrolled experiment on the human population, and I predict that it will end very, very badly. I predict it will end in class action lawsuits and drugs being taken off the market, because the GLP-1 receptor is definitely in your gut. It's definitely in your brain. We know that. But it's also in your kidney. It's also in your liver. It's also in your arterial walls. What are these GLP-1s? What are they doing to all those other GLP-1 receptors? Well, we don't know. And now we've bumped up the dose, in many cases doubled the dose. What effect is that having on all these other receptors in every other part of your body? We have no idea. There actually is an experiment going on right now, but you, my dear patient, are the guinea pig if you're taking a high-dose GLP-1. We'll see how it turns out.
Yeah, yeah. There's some pretty scary long-term effects. The loss of muscle mass and bone mass. I mean, we spend half our time trying to get older people to maintain their muscle mass and bone mass, and boom, you take a drug and it's all gone.
Yeah, and that's something that many patients don't know, but every doctor should know this, that muscle and bone show up on the bathroom scale, just like fat does. And so if your patient has lost 20 pounds over the last month, was that fat, or was that fat and muscle, or was that fat and muscle and bone strength? I'm not a big proponent of muscle loss myself. I like to stick with just fat loss and optimizing muscle. And the GLP-1s don't do that, as the new recent research you just intimated showed very clearly. There's a significant degree of muscle loss in that weight loss, and nobody wants that.
So, Ken, we've focused mainly on type 2 diabetes and obesity. What about some other conditions that you feel benefit from this sort of dietary approach of a low carb, ketogenic, carnivore diet? Is it just the sort of the diabetes thing, or in your experience, as a practicing clinician, you obviously see people with autoimmune disease, with neurodegenerative disease, with mental health issues, and so on. I mean, what's your experience with those sort of conditions?
What I would say is that a very low carbohydrate diet, whatever style that you think is sustainable for you, is going to improve every metabolic marker that we can check. So your body, metabolically speaking, is going to get healthier in every single way. And that's very important for, obviously, obesity, obviously for type 2 diabetes, prediabetes, and type 1 diabetes as well, not, of course, but also hypertension. In my experience, 90% of essential hypertension or idiopathic hypertension is just hyperinsulinemia. Once you get the insulin back down to normal, the hypertension goes away 90% of the time, right? What about hypertriglyceridemia? High triglycerides back to normal. What about low HDL? If you're eating enough red meat, it's gonna actually go up better than any prescription medication can cause your HDL to elevate. A very low carb diet that's very red meat heavy is going to raise your HDL better than any medication you can get at the pharmacy. Now, what we're discovering now with the work of Dr. Georgia Ede and Dr. Chris Palmer is that mental health, lo and behold, the human brain is connected to the human body. It's actually part of the body. It's not a magical thing. It also suffers from metabolic syndrome, metabolic disease, hyperinsulinemia, hyperglycemia. And so when you eat a diet low enough in carbohydrates to improve your metabolic health, your mental health is going to improve as well. Not just depression, anxiety, but also more touchy things like OCD and bipolar disorder and even schizophrenia now. There's research coming out to show that a ketogenic diet can help improve these mental conditions. And then let's talk about the gut. What about eosinophilic esophagitis? What about reflux gastritis? What about ulcerative colitis? What about Crohn's? What about IBD and IBS? Lo and behold, all of these things also improve when you get rid of all of the high carb, ultra processed crap and focus on eating very low carbohydrate, real human food. What about the skin? What about psoriasis, eczema? What about acanthosis nigricans? What about chicken flesh? There's a lot of young people who have this rough skin on their arm or their thighs, pityriasis, and it just goes away. When the insulin level goes back low enough, the eczema goes away, the psoriasis gets 90% better. You went from having half your body covered to now you've got a little spot of psoriasis on your calf as big as a nickel or something. So I have yet to find any metabolic associated disease that doesn't improve, right? And so now we start looking at, especially with the carnivore diet, we start looking at seemingly incurable things like multiple sclerosis. And now my good friend, Dr. Sean Baker, he's got 3 or 4 documented cases of MS going into complete remission, including white matter disease disappearing on a repeat MRI. Right? And so these are just anecdotes at this point, but I mean, how many anecdotes do you have to have before it means something? I don't think we know the answer to that, but here's the take-home argument. What we're recommending to you, Peter and I and all the other carnivore and keto doctors, we're not recommending to you some brand new weird chemical thing made in a nuclear factory. We're just saying stop eating food that's made in a factory and start eating the food that human beings have always eaten and stick to that exclusively and keep the carbohydrate intake level under some total amount. For some people, it's under 100 total grams and all their conditions go away. Some people, and I like to talk about it like a carbohydrate intake knob. You know the knob, remember when stereos used to have knobs? And you would turn down the volume? Same concept. Start with 100 total grams. Do it for 3 months. Recheck your labs and see how you feel. If that did it, great. Huzzah, you're done. Go live your life. Go outside and play and be happy. If that didn't completely reverse all your conditions, then turn down the carb knob down to 50. Try that for 3 months. Recheck everything. Then if that fixed it, great. If it didn't, go to 20. And then keep turning down the carbohydrate intake knob until all your labs are normal and you feel great. that is your spot on the proper human diet spectrum. You have now discovered something invaluable about your own physiology. And you can use that each and every day for the rest of your life to stay healthy and to stay happy.
Yeah. Yeah, I think everyone has their ideal carbohydrate, intake, and it's a matter of trial and error, and you've got to find the right one for you, and that can change. You can start off really hardcore keto, and then you can relax a little bit once you get everything under control. That was certainly my experience. Okay, we'll come back to a couple more from me later on, but we've got a whole bunch of questions from our listeners, Ken, if you don't mind. Well, the first one is from Jamie, and it's interesting. It talks about protein. Now we push, a lot of people, Ted Naiman and people like that, suggest that the recommended protein intake of maybe 1 gram per kilogram is not enough, and especially in older people that it should be 1.5, even 2 grams.
Yep.
And Jamie's saying that she has real trouble, getting that amount of protein. As she says, for a woman of 60 kilograms, 90 grams of protein over 3 meals is tough. When you like 2 eggs is only 11 grams of protein. That's a lot of eggs and so on.
Right.
So, what's your views on protein and your sort of guidelines on eating protein?
So the way the protein recommendation is calculated is not on your current body weight. What was her name?
Jamie.
Okay, Jamie. We're not, you currently weigh 60 kilos, I think you said. Is that right? But we're not going to calculate your protein needs based on that number. What we're going to do is figure out what's your ideal body weight. Now, keep in mind, that's only a suggestion. Nobody on planet Earth knows what your specific ideal body weight is, but we do know a range. And so with your height and your frame and your age, we can say, oh, well, your ideal body weight, let's say you're 5'6", your ideal body weight's probably 120, 130 pounds. Now, you're going to do that calculation on your ideal body weight, okay? And I think that the needed protein intake is somewhere between a pound per kilo or ounce, a gram per kilogram, all the way up to a gram per pound of ideal body weight. I think that's the range. And just like carbohydrate intake, I think people have different protein needs. If you're super active, you may need more. If you're more sedentary currently, then you might not need quite as much, but you're going to need somewhere between 1 gram per kilogram and one gram per pound. And you can do the conversion, and then you'll know your range. And I think you'll find that range much easier to hit. But I typically, it's usually women who have trouble getting in enough protein. And what I also find is when you're starting, Jamie, it can be very hard, because when you start eating lots of animal fat and animal protein, both of which are very healthy for you, it can almost turn your appetite completely off. Like, I'm just never hungry. And that typically happens only to women. It's rare that it happens in a man. Men, you know us, we're insatiable. We're just going to eat all the time, whatever, doesn't matter. We found it beside the side of the road. We're going to eat it. Doesn't matter. But women, but that's not going to be permanent, Jamie. What's going to happen is, as you're losing body fat, keep in mind that body fat doesn't just float in midair. It's held in place by connective tissue. And as you metabolize and get rid of that fat, which you're going to breathe out and pee out, that's where the fat goes. That connective tissue is no longer serving a purpose, and your body's going to recycle that. And so you're also going to get the added benefit of those amino acids that your body can then recycle and reuse to build muscle and other things that need protein. So what will happen is, eventually, when you've lost enough of your body fat percentage, your appetite's going to increase. And then you'll be like, oh no, I'm hungry again now. I can eat more. So, but for people who are severely obese and they're like, I'm not hungry, I eat one meal and it's like 800 calories. I'm like, number one, stop counting calories, because that's useless. Number two, eat until you're comfortably stuffed, and trust this million-year-old technology that when you've lost enough fat and recycled enough connective tissue, your body's not an idiot. It's going to increase the hunger hormones, and you're going to be more hungry, and you'll eat more meat.
Fantastic. Great. Well, I hope that solves your problem, Jamie. I've got a question from Greg about the dawn phenomenon. We have mentioned this before in webinars, but maybe briefly explain the dawn phenomenon, what's your understanding of it, and should we be concerned about the dawn phenomenon?
So before I went to medical school, my undergraduate degree is in animal biology, in the comparative anatomy of primates. The dawn phenomenon, and I get flack for this, Peter, and you may disagree with me on this. The dawn phenomenon is in 100% normal, healthy phenomenon. It is not pathology. It is not your enemy. Every mammal, the cow eating her grass, she has the dawn phenomenon. The little mouse that you cannot get out of your house has the dawn phenomenon. Every mammal on planet Earth that's ever been measured, they have this. It is normal mammalian physiology. Okay, now it can be more pronounced in people with metabolic disease. It can really skyrocket your blood sugar if you have prediabetes, type 2 diabetes, metabolic syndrome. But it is a normal phenomenon. It's not bad. It's physiology, not pathology. And so know about that. And the only concession you're going to make is you're not going to check your blood sugar or your blood pressure immediately upon waking. You're going to say, no, the dawn phenomenon is normal physiological behavior for every mammal on planet Earth. I'm going to wait an hour or two after I wake up to check my blood glucose or my blood pressure to allow time for the epinephrine and the cortisol to clear so that I can get true readings. And stop worrying about the dawn phenomenon. It's not pathology. What say you, Peter?
Completely agree. I agree, and I'm
okay,
sure
all
that's
right,
great
good
advice
okay,
for Greg.
Okay. So we're still friends. Okay.
Still friends. Yep. We've talked a lot about, and we know there's a close association between obesity and type 2 diabetes. But Bridget's got a question about what advice have you got for skinny diabetics? Because we do see those, and how do you approach those?
So first of all, you're in much, much more danger than a fat diabetic. You're at much higher risk of heart attack and stroke. Okay. So I wanted to scare you a little bit. Are you scared? I hope so, because I wanted you to be. But now here's the answer. Now, first we have to say this, and everybody listening, listen carefully. This is important, and you may have never heard this said in your entire life. Ketogenic diets and carnivore diets are not weight loss diets. They are weight optimization diets. I've seen many, many underweight people gain weight on keto and carnivore. People who need to lose weight tend to lose weight on keto and carnivore because it's a proper human diet. It's going to move you towards your proper ideal body fat percentage and ideal body weight. So if you're a skinny diabetic, I want you to be very motivated to start either keto or carnivore immediately. Don't wait till January 1. I want you to start with your very next meal. And I would really, really love it if you would do 90 days of only beef, butter, bacon, and eggs, because you're in real danger. We've got to get the blood sugar down. We've got to get your A1C down. We've got to get your insulin down. I don't know if you're type 1 or type 2, but either way, I guarantee you have hyperinsulinemia. You're either injecting too much or your pancreas is making too much, both of which are equally as dangerous. You've got to cut the carbs to as close to zero as you can get it. You will not lose more weight. What happens very often for skinny diabetics is when you get the blood sugar and insulin under control, they start to gain weight, but it's not fat. Remember, there's three things that show up on the scale. There's fat, there's muscle, there's bone, and then all the connective tissue. You're going to start to put on muscle naturally without even going to the gym. Not a lot, just a little. You're going to start to strengthen your bones by eating this nutrient-dense diet, and you're going to start to strengthen all of your connective tissue and your other organs. You're going to get rid of the fat from your liver and your pancreas. Fatty pancreas is a real thing most doctors have never heard of. All that's going to get better immediately. Your blood sugars are going to start to go down. You're going to put on muscle, and if you've got any fat, you'll lose that. But it's not a weight loss diet. It's a health optimization and a weight optimization way of eating. Just think about it. If I locked someone in my barn and starved them for 3 months, and they were 6 foot tall and weighed 80 pounds, and they escaped my barn, but they escaped from my barn into my kitchen, and the only diet they had access to was a carnivore diet, do you think they would continue to lose weight? No, they would start to put on healthy weight immediately on starting to eat the beef, butter, bacon, and eggs. Does that make sense? I hope that helps. Please, please, you got to go low carb immediately.
Okay. Look, I think we've answered a lot of the other questions over the last, hour or so from Sonia and Janet about statins and about Ozempic and so on. So we're almost out of time, Ken, but I just want to talk about how we change, and particularly how we change the medical profession, and there are so many doctors out there who are just unaware of this. Now I know you've started an organisation called the American Diabetes Society, and tell us your plan, I guess, or your aim into trying to sort of get the medical profession on side, because it's incredibly frustrating, and I'm sure you find that too. That almost the biggest impediment to health is the medical profession, which is saddens me to say that as a member of that profession, and we need to turn that around.
The truth needs to be told, no matter how sad it makes you, right, Peter? So we did, me and Professor Ben Bickman and Dr. Eric Westman and Dr. Tony Hampton and Dr. David Cavan in the UK and Dr. Mariella Glant in Israel, we got together and founded the American Diabetes Society. And its primary goal is going to be patient education. But we are going to be promoting ketogenic or low carb dietary guidelines that doctors can recommend, as opposed to the ADA guidelines, which don't help. You'll truly be a partner for life if you follow the ADA guidelines. But if you follow the ADS guidelines, you'll be a former type 2 diabetic. And that's what the ADS would like for you. We don't want to be your partner for life. We want to just cure you and let you go live your life. So that's the thing. But here's my big picture take on this, Peter. All of us went through the events that happened in 2019, 2020, 21, and 22. And I think everybody is much more aware now that just because their doctor says a thing does not mean that that thing is in fact straight from the gospel. And I think that people are looking for solutions in other places. They might still go to their doctor and listen to their doctor and smile and nod politely. But if what their doctor tells them is what we here in the South call bullshit, then that patient is going to go and say, I don't know, how is eating more carbs, how's that going to help my diabetes? I don't understand that. Okay, I'm just going to look around. And then they find my YouTube channel, or they find your work, or they find, any number of very, very good healthcare providers out there on YouTube and other social media channels. And they're like, that makes more sense. So my sugar's high, so I should eat less sugar. And all carbohydrates break down into sugar, so that means I should eat less carbs. That sounds like low carb, and even lower carb than low carb is keto. Okay, so I'm going to play around and see how this works. And what I've seen is a vast number of people get the BS advice from their doctor and either try it and it doesn't help, or say, it makes sense, and they go watch some of my YouTube videos. They completely reverse their type 2 diabetes. They go back to their doctor for a recheck, and he's like, oh man, your A1C looks great. You're doing so much better. That plant-based diet. And then the patient proceeds to educate the doctor. And I'm seeing this happen thousands upon thousands of times. And doctors don't appreciate that typically. Sometimes they get emotionally upset. But when, if they hear that from one patient, then they'll just have a bad day and forget about it. But when they hear it from the second patient and the third and the fourth and the fifth, at some point, they're going to go home and they're going to Google it. And then they're going to be low carb, keto, woke, just like their patients are, and they'll get up to snuff. I predict this is going to be a ground roots, almost a reverse education. The doctors are not going to be educating the patients. The patients are going to be educating the cow's tail of the doctors who are behind this low carb keto carnivore curve. They think it's weird or a fad or whatever. And after they've seen 10, 20, 30 patients reverse their metabolic disease, they'll stop saying those stupid things and they'll start to recommend a proper human diet for every single one of their patients.
Yeah, no, we see it happening all the time. And some doctors are open to it and some are pretty reluctant. But anyway, Ken, look, our time's almost up. how do people find you? You've written a great book, Lies at Medical School Told Me, or which is
Lies My Doctor Told Me.
I've tried to find it this morning. I think I've lent it to someone and they haven't given it back, so I'm going to have to chase that up. But